Dear colleagues, ladies and gentlemen, I'm very honored to be part of the 17th World Congress of Anaesthesiology, which puts us virtually to Prague. Sitting now in a virtual Charles IV room, German Emperor and Wenzel of the Bohemian Kingdom. Preventing respiratory failure in the elderly is my topic today, and as the rabbit from Alice in Wonderland tells us, I don't have much time. I have 10 minutes, possibly 12 minutes, to tell you what I think is important. I'll talk to you about the respiratory changes, system and its changes. Included in that, we talk about comorbidities and consequences. We talk about the impact of general anesthesia and what it does to our respiratory system, especially in the old person. And most importantly, we talk about preventing measures. What can we as anaesthetists do? We talk about physiology, we talk about a complete changed body, of course. You're not simply old in one and not the other organ. We look at this, what is now in the center of this picture, and I put it out. We talk about the lungs, we talk about the diaphragm, what is not on here, but the former picture, the rib cage, everything around lung and diaphragm, so all the respiratory system. And what will we see is that we have in an old person a decrease in compliance of the rib cage, which makes breathing more difficult. We have a faster airway closure, so we will develop, when we get old, increased functional residual capacity or residual volume, or both. So the parts of the lung that really inhale and exhale is reduced. Something we call senile emphysema occurs. Resulting is a change in the VQ ratio, which will consequently form shunt. So oxygenation is simply reduced because blood goes through parts of the lung and doesn't get oxygenated. Consequently, PO2 decreases if we compare that to a young person. It doesn't mean that a 100-year-old person doesn't oxygenate at all. It remains stable from around 70 years, but it's reduced around PO2 over around 70 compared to 100 in a young person. And additionally, diaphragm force is reduced by age. We have a reduced muscle mass, and you may not forget that your biophysics may change. Think of an old woman with a torquated column standing like this in front of you and trying to breathe. Of course, the respiratory system is less effective than in me. When we think about old people, we think about all kinds of comorbidities, and I've shown you in the first table of contents this little X-ray of a emphysema lung, and you see here the CAT scan attached, and you see when you have now a 3D reconstruction how many parts of the lung don't take part anymore in gas exchange. And when you have such a patient in front of you, you will realize that he is not very tolerant to apnea and will need some special care of you. What I don't talk about in this talk, because it would really not allow me to talk simply 10 minutes to you, is that of course when we think about the lungs, we think about the heart, and when we think about the heart, we think about the lungs. It's a very close interaction. So someone with a left ventricular problem, with lung edema, after your treatment will have respiratory function problems you have to take into account. So what happens now when we add general anesthesia to an old patient with possibly impaired lung function? Mechanical ventilation induces several things. At first, an upward shift of the diaphragm, so the transpulmonary pressure is reduced, and this forms atelectasis. Resulting from atelectasis is shunt, so we have an oxygenation problem. We have a reduction of the mucociliary clearance. So especially in someone with a high mucus production, like a COPD patient or an asthma patient, will not clear his airways. 6 hours later, when you pull the tube out, you will realize that this may result in a problem for the patient. You may have possibly overinflation, especially in a patient that didn't take his medicaments because he forgot it in the morning. You may induce bronchospasm when you may put in the tube and your general anesthesia level is too light. Postoperatively, you'll see bradypnea or hypopnea. Why that? Because you chose a bit too much of opioids and maybe the one or other milligram too much of, let's say, rocuronium in that case. So as Jean-Luc Picard here in this famous chair on Enterprise 2, what shall we do now? Now it's on us to decide what's best for our patients as anesthetists. We have to think about preventing measures, and this directly, and Uncle Sam points to us directly, not for joining the US Army, but joining the team that knows the patient. So please know your patient. Know his lung function, have an idea about the frailty he'll have. Is he able to walk 2 stair levels or not? Still riding a bicycle or not? Is it possible to improve his lung function preoperatively? Does it help to give him better tube mimetics or not? You see here in this picture, in the upper part, this asthma patient, it really does help. In the COPD patient, where everything you may imagine in the upper part of the lung is an emphysema bulla, it doesn't help to put even better tube mimetics. It's maybe just bad for the heart because the patient gets a tachycardia. Is there a need for mechanical ventilation? Do we really have to start general anesthesia? Is it necessary? Other question, can we reduce opiates or maybe combine regional anesthesia in whatever way, or simply use regional anesthesia and no general anesthesia? The work group of Mark Coburn did a systematic review and meta-analysis asking the question, is it better to use neuroaxial anesthesia, so spinal anesthesia, versus general anesthesia in hip fracture patients? And they didn't find, according to pulmonary function, not too much. You see, there is no real benefit using neuroaxial anesthesia, maybe simply because when you look at 6.1.2 randomized controlled trials, we talk about 700 patients in this meta-analysis included. We are expecting a larger trial which may give us an answer on that. Although from my physiological and pathophysiological understanding, of course it makes sense in a very old person to omit general anesthesia and choose something where he can stay awake, where his respiratory function is not impaired. So when you have your patient now in your OR, you are the anesthetist. Consider pre-oxygenation using PEEP, especially in obese patients. They already have atelectasis, and directly after using propofol in a very nice dose, you'll have more atelectasis. Prevent them as when you can. Of course, use PEEP during the surgical procedure. This is part of lung protective ventilation. There is no study in looking at old people if there is really a benefit to use lung protective ventilation during a 3-hour surgery. I don't think that you'll find any benefit, any proof of benefit, but I'm completely convinced that it surely does not harm. So do it, please. Careful monitoring of overinflation, especially in COPD patients, is necessary. That means look at your flow rates, look at your carbon dioxide curve. Does it flatten? Does it give a plateau? So then change your I/E ratio. Think about a pharmacological treatment. It's important to measure the train of 4 so that you can really titrate your neuromuscular blocking agents and not just give it from a feeling that he may need something, especially when the surgeon is crying that the patient is too stiff. Prevent partial muscle blockade post-surgery. It will help the patient massively if he can use all the muscles he wants. Be careful in volume management. A patient with an impaired left ventricular function does not like it very much if you infuse 3 liters in 2 hours. That will end in an chest X-ray as I've put it on the slide on the right side. And I guess you'll agree to me that this patient will have impaired respiratory function afterwards. In the recovery room, treat atelectasis. But how? We know from patients with acute respiratory failure that high-flow CPAP has a very nice benefit, even better than pressure support ventilation. Does it help after surgery? It's a question the work group of Emmanuel Fouquier and Sami Jabert has asked in the OPERA trial. And in the OPERA trial, couldn't find a difference if you see high-flow nasal cannula oxygenation or usual care, which means oxygen. We see that just 112 versus 108 patients have been treated, and the numbers were maybe much too low to really find out if post-pulmonary complications, PPC, you see here at the axis, that it may influence these post-pulmonary complications. From a physiological view, it may make sense, as we see in the next slide. Treat pain successfully. Remember that the patient with a drain in his chest has pain when you don't treat it successfully, either regional or central. In every breath, or with a large abdominal wound, he will not breathe sufficiently. Treatment of delirium is highly important. Someone who thinks that he's in a different world may not breathe sufficiently, but is maybe using all his energy to fight whatever he thinks is around him. So please treat delirium. What's now the difference between a critically ill patient and a post-operative patient? The difference is that the critically ill patient has a lung affection, which affects the complete lung, while we usually treat atelectasis, minor or major atelectasis. And patients with minor atelectasis, they may simply need oxygen, someone who tells them to cough deeply, and maybe we can, when it doesn't work, add high-flow nasal cannula or simply CPAP, whatever version you have in your OR. Patient with a major atelectasis, he may need more pressure, so maybe positive airway pressure in sense of pressure support ventilation. And the 6 centimeters of water you can reach with high-flow nasal cannula, CPAP, is simply not sufficient to open up such a lung. And those patients may have post-operative pulmonary complications that we can really measure, atelectasis the next day and so on. So think of atelectasis as something you have to treat directly in the OR, and the ones with major atelectasis, let them sit up in bed if it's possible. Let them cough. Give them positive pressure that it really opens up the lung. And before you let them leave the recovery room, atelectasis must be open. What take-home messages should you take? Remind, please, the pulmonary, functional, and muscular limitations in your old patient. Remind possible comorbidities. COPD, what does it mean? Think that general anesthesia influences negatively respiratory function. That's a fact, and you have to think of whom to apply general anesthesia. Is it really necessary to do it? And that's the most preventing measure. Avoid general anesthesia when it's possible. Combine anesthetic techniques, which will result in less opioids. We don't use neuromuscular blocking agents, and we can also maybe reduce delirium, which is also a case for respiratory function impairment. Please, aggressive treatment of pain and bronchospasm, everything that may affect the patient. Treat atelectasis in the recovery room. Think of, is it just minor? Do I have a major problem? Can I open it up with a bit high flow oxygen, maybe simply oxygen coughing? Or does the patient really need positive pressure ventilation, maybe using a face mask? Treating the old patient is something that means understanding the patient as a whole thing. It's a multi-organ problem that we are treating, and hopefully these, I guess it's now 13 minutes, will help you to do so. And I may tell you a very warm thank you from Aachen. You see this bust on the left side. That's Charles IV. He wanted a bust for when he became German king in Aachen and coronated here for Charlemagne. So it was Charlemagne that you see here, but Charles IV said, I give the money for it. So please put my face on this bust. So Charles IV tells you, bye-bye.